And in vasculitis, this could be vasculitis that's Wegener's granulomatosis or Churg-Strauss syndrome, polyarteritis nodosa, Churg-Strauss syndrome, Wegener's granulomatosis, microscopic polyangiitis. All of them have a lot of things in common. They all have in common the fact all of them give you fatigue and tired and weight loss. They all do that. That's not going to help you answer the question. That's not going to help you say what's the most likely diagnosis, because they all do that. And they all can give you a fever. They all can give you anemia. They all can give you skin lesions and purpura, petechiae and purpura and tired and joint and skin and joint and skin. They all can do that. They all can do that. That's not going to give you the diagnosis. Wegener's gives you joint pain. Polyarteritis nodosa gives you joint pain. Churg-Strauss gives you joint pain. All of them do. The same way they can all give you neuropathy. Remember, mononeuritis multiplex? Is it a mono? Is it a mono? Or is it a multi? Is it a mono? Or is it a multi? And the answer is, it's multiple peripheral nerves large enough to have names. Ulnar and a perineal. A dorsalis, tibialis, foot, radial, and wrist drop, and a perineal. Multiple large peripheral nerves, large enough to have names. Now, vasculitis does that because vasculitis is a problem of the vasonervorum. Vasa, blood vessels, around the nerves. So it inflames, chokes off those nerves. Big nerves have blood vessels around them. Big nerves have vessels. Vasculitis inflames them. Causes purpuric skin lesions. What's the difference between a purpura and a petechiae? Size. Right now I'm just a little petechiae, but someday I'll grow up and be a big purpura! Size. When it gets bigger, it's purpura. What's the difference between the macular rash of a drug reaction and a purpura? What's the difference between the macular rash of a penicillin allergy and purpura? The answer is not blanching. Doesn't turn. See? Ooh, look, turn. Oh, see, my head turns white. Oh, look, it's blanching. It's not a vasculitis. It's not vasculitis because my blood vessels are intact. See, I'm turning white. Look, see, it's not blanching. That's blanching. That means my blood vessels are intact. See, but a person who's got vasculitis, you can press on it and it stays red. Press on it, it stays red because the blood vessels are damaged. Also, petechiae, you press on it and it stays red because in petechiae, the blood vessels are damaged. But drug reaction, the blood vessels are not damaged. Drug reaction, blanches, turns white. Drug reaction, blanches, turns white. Vasculitis does not. Now, vasculitis causes an anemia of chronic disease. Normochromic, normocytic anemia just stops the marrow from growing too well. All of them cause a high sed rate. All of them make an inflammation, and evidence of inflammation cause high white counts and thrombocytosis. But all of these things are nonspecific. The most accurate for all of them is a biopsy. Now, and all of them can be treated with, come on, rheumatology, steroids. And if ineffective, cyclophosphamide. So we've done it this way because I want you to learn it like this. I don't want to learn these things over and over and over again. I don't want to say petechiae and purpura and joint and skin and stroke at a young age and GI bleeding for no particular reason. I want to be able to say, okay, they all do that. They all can be biopsied. They all get steroids. They all can get cyclophosphamide. Why don't you just tell me what's different? What is different about each one of these? They all can get azathioprine 6-mercaptopurine. But what's different? Rarely methotrexate. Well, what's different is that polyarteritis nodosa skips the lung. That's the big difference. Polyarteritis nodosa skips the lung. And if you said, well, what is the most common presentation? It's abdominal pain. If you said the most common presentation, it's abdominal pain. Abdominal pain because of vasculitis of the GI vessels. Abdominal pain. Now, renals and all of them can cause renal, but polyarteritis nodosa is particular to abdominal and renal. Now, it spares the lung, but all of them can do all of these things, but what's the difference? Well, you see, the problem with polyarteritis nodosa is there's no really good blood test for that disorder. There's no good blood test for that. There's no really good blood test. P-ANC is only in 20%. P-ANC is in 20%. What infectious disease is associated with PAN? The infectious disease associated with PAN most likely is hepatitis B or C, but a chronic hepatitis. What's this sural nerve biopsy? The sural nerve? Well, we do the sural nerve biopsy because it's down in your leg. It's down there in your leg. We do the sural nerve biopsy because it's a lot easier and more accessible than a kidney biopsy. So we're trying to avoid the kidney biopsy. The most accurate test is a biopsy. But what you can do first is P-ANCA and angiography of the vessels. Because if you see this beating and narrowing, it's polyarteritis nodosa, and I spare myself the kidney biopsy. Spare myself the kidney biopsy, but you have to get some tissue proof. Then polyarteritis nodosa, this is not different. Steroids and cyclophosphamide, that's not different. That's the big difference. PAN, no lung, no lung, no lung. Hepatitis B and Abachibo. What's different about Wegener's granulomatosis? It can affect the majority of the body, but it hits the upper and lower respiratory tract. That's the major thing. It starts out in the lungs more than the others, and especially sinusitis and otitis. Sinusitis and otitis, sinusitis and otitis, sinusitis and otitis, upper respiratory problems. Upper respiratory problems, sinusitis and otitis. And that C-ANCA is very specific for Wegener's. C-ANCA for Wegener's, P-ANCA for Churg-Strauss. P-ANCA for Churg-Strauss. Now the most accurate test of all of these is biopsy, and they all get treated with cyclophosphamide and steroids. Cyclophosphamide and steroids. Now Wegener's granulomatosis will not jump out as you as a person says, man, I got a cough and I got hematuria. Yo, you must have Wegener's, man. No, it's going to present like a person who's having multiple episodes of pneumonia. And you're like, what's going on with this person? Why are they having pneumonia? Because you don't think first about Wegener's, you think first that it's pneumonia or just sinusitis. It comes across like an infection. Fever, cough, hemoptysis, then it gets better, then it comes back, then it gets better. It doesn't really respond to antibiotics because it's a vasculitis. But remember, it's going to be the chronic recurrent cavitary pneumonia. The chronic recurrent cavitary pneumonia with systemic manifestations up and down the body, but predominantly sinusitis, otitis. Now, Churg-Strauss is easy because it's the only one that has eosinophils and asthma. Eosinophils and asthma is Churg-Strauss, so from that point of view, this is the easiest one because it's the only one that's characterized by the eosinophils and the asthma. That's very, very easy. And biopsy, an excellent response to steroids, Churg-Strauss, P-ANCA. Temporal arteritis is a type of giant cell arteritis, and the big question is always this forever overly asked question about the person comes in with visual disturbance, and do you wait for the biopsy to give the steroids, and you're supposed to not be a doofus and say, yeah, let's wait for the biopsy until they go blind. And that question is asked entirely too much. It's one of the only things people know, but what you don't know is that they present with jaw claudication. I'm chewing, ow, oh, ah. Jaw claudication starts to hurt a lot when you continue to jaw bone. Clearly, I do not have temporal arteritis because I've been agony because my mouth never stopped moving. Fever, weight loss, malaise, fatigue, biopsy is the most accurate test, Sedrate is the best initial test, and give steroids prior to waiting for the results of biopsy. Boring, just look for the jaw claudication. Would you please look for the jaw claudication? Thank you very much. Now, Takayasu's arteritis, great disease, pulseless disease, young Asian females, it's true. That's a real demographic. It's a real demographic, young Asian females, absolutely. Decreased pulseless disease. Well, how can you get a question on this? I mean, it's so obvious, right? It's one of those things that really sticks out in your mind in medical school. It really is in Asian females, it really is pulseless, and you use steroids because after all it's an arteritis. The question that is most frequently asked for you is, fine, you know what, it's step 3. Here it is, I'm presenting you a pulseless Asian female. Another one? Really? Thank you. Is it my birthday already? No, you idiot. What are you going to do first? Well, I'd give steroids, I suppose, but no. What's the most accurate test? Well, it's a Takayasu's. Yeah, but what's the most accurate test? It's an arteritis, I'd do a biopsy. It's vasculitis, okay, before loss of pulse. I'd do an arterologist, biopsy, it's an arteritis. Biopsy, Sedrate. Biopsy, TIA stroke, let's biopsy, it's a vasculitis. Let's biopsy, do a vasculitis. Aortography, MRA, it's a vasculitis. And the most accurate test is not a biopsy. This is the most frequently incorrect question for you. The main thing you come out of step 3 high yield for you today is to basically to say, yes, it's an arteritis, yes, it's a vasculitis, but don't be biopsying people's subclavian, would you? Oh, I must take a piece out of your subclavian artery. Give it to me. And then, look, I took a piece. Wrong! Don't biopsy people's main arteries. Hey, Matthew. Hey, oh, thanks for the biopsy. No. Treatment is steroids because it is an arteritis. Just don't yank holes out of people's main arteries. Thank you very much. Cryoglobulins. What is the difference between the cryoglobulins and the cold agglutinins? And the cryoglobulins and the cold agglutinins? Well, the major issue is they're completely different in their manifestations. It's just that they both have the word cold, and they're both IgMs. And neither of them is particularly good with steroids. Cryoglobulins, although it's an IgM like cold agglutinin, cryoglobulins is from hepatitis C. Cold agglutinins is from Mycoplasma Epstein-Barr. Cryoglobulins causes kidney problems, causes kidney, joint, skin, kidney, joint, skin, kidney, joint, skin. Cold agglutinins causes hemolysis. Cryoglobulins doesn't cause hemolysis. Now, the hepatitis C, if it's from hepatitis C, you treat the cryoglobulins with hepatitis C. Interferon, ribavir, and either telaprevir or boceprevir. Telaprevir or boceprevir, and just because you haven't heard of it doesn't make telaprevir and boceprevir wrong. Great drugs, very few side effects, and they bring the response for hepatitis C up to 70 or 80%. You treat the hepatitis C. Now, for cryoglobulinemia, not from hepatitis C, those people, we're going to say answering steroids and plasmapheresis sometimes. That's a change, okay? Because some of the older stuff you'll see it says steroids don't work at all. What we mean to say is that steroids are not good for the cryoglobulins from the hepatitis C. If it's essential mixed cryoglobulins, which is just like sometimes bad cryoglobulins happen to good people, you might have to use steroids and plasmapheresis for that kind of cryoglobulin. But for hepatitis C, no steroids. Treat the hepatitis C. Remember, cryoglobulin is very simple. As long as you remember that it's from hepatitis C, it causes skin, kidney, joint problems, and just treat the hepatitis C. Also remember that this is the most frequent thing to be, okay? You would think that the whole world was filled with cryoglobulins, the way that this thing is on every test. You would. You'd be like, man, it's like the American Cryoglobulin Association. Yeah, it's there all the time. Remember, rheumatoid factor is a cryoglobulin. So essentially 100% of people with cryoglobulins have a positive rheumatoid factor. Behçet disease. Behçet was a Turkish dermatologist, worked and published in the 1930s, and this is really true about the Middle Eastern, Asian ancestry, or current. It doesn't have to be ancestry. You'd be like, it's not ancestry. Yeah, ancestry. What are you talking about? I live in Turkey, you turkey. Yeah, but you got Turkish ancestry. Well, it doesn't have to be. It could be Turkish and Middle Eastern currency, I suppose. Oral and genital ulcers, it tends to look like reactive arthritis. It can look like reactive arthritis. But the difference is a different type of genital ulcer, and also the ocular involvement is uveitis and optic neuritis, not conjunctivitis. Conjunctivitis is with Reiter's syndrome or reactive arthritis. But this is the biggie. This ocular involvement will blind you with Behçet's. Blind you. The skin lesions are pathogen. You scrape the skin, scrape the skin, scrape the skin, and a sterile abscess forms. Scrape the skin, and scrape the skin, and a sterile abscess forms. Behçet's disease doesn't have a specific test. That pathogen is not really a specific test. Remember, you can go blind from it. It causes genital ulcers, and you've got to rely on the clinical constellation that we just saw here. Now, the treatment is fortunately prednisone and colchicine as Behçet's, and there's nothing new on that. Behçet's, prednisone, and colchicine. Thank you so much for listening, and remember, this whole trip is worth it. You're going to be super great. Going to be super great. They need you. You are indispensable. I'll see you in the next section.